So we have a 42-year-old lady. She has fatigue and exertional dyspnea. She has difficulty walking for more than 1 or 2 blocks without becoming short of breath. She uses 2 pillows to sleep, and she has hyperlipidemia, hypertension, type 2 diabetes. She smoked a pack of cigarettes 15 years but quit 10 years ago. And at the moment, temperature is normal and respiratory rate is 16. But BMI is 55 kg per meter square. It's very obese. JP distension difficult to visualize due to thick neck. Lungs are clear to auscultation without wheeze or crackles. Okay. Heart sound are distant. Maybe she's very obese. Definitely. Abdomen is obese and non-tender. Trace bilateral lower extremity edema. Neurological examination is within normal limit. And chest X-rays of poor quality due to underpenetration, but otherwise no obvious abnormality. EC shows low voltage, QRS complex, but no significant STT wave changes. And this again due to very high obesity. Obesity causes low voltage ECG. Well, before I proceed further, write down the answer. Tell me some other causes where we get low voltage QRS complex ECGs there. Well, the answer of this question is, this may be sometime it may be a normal variant, but otherwise it is seen in hypothyroid. Okay, hypothyroid. It can be seen in severe pericardial effusion. But this is a very important cause. Don't forget hypothyroid. We move further. As far as the lab reports are concerned, hemoglobin level definitely it is raised. Other are normal. If you look into ABG, it is slightly on the acidic side. O2 is reduced and CO2 is increased. Which the following the predominant cause of this patient dyspnea? Well, we are getting a very obese lady with no abnormality in the chest finding as such, including X-ray. Okay, but has a short breath as soon as she walks. The answer to this question is alveolar hypoventilation. Okay, so what we call as OHS, obesity hypoventilation syndrome, OHS. First, we learn how we define this condition. Daytime hypercapnia, in our case 45, and in our case it is 59. Obese patient, BMI more than 30 kg per meter square. Okay, but in our case it is 55. Okay, without any other explanation of hypercapnia. There is no other reason why hypercapnia is there. Now, most patients have coexisting obstructive sleep apnea is there. And with the result, frequent apneic event and daytime hypersomnambulism, the patient tend to sleep during the daytime. Now, other feature dyspnea, yes, she has the problem. That's the main problem for which patient has come to us. She's not able to walk even 1 or 2 blocks. She feels short of breath. Polycythemia, hemoglobin level is 16 grams. This is secondary to hypoxia. Okay, and remember, in this case, PaO2 is 70 only. The hypoxia which is causing polycythemia, this is so-called secondary polycythemia. In this condition, erythropoietin level is increased. So any condition which lead to chronic hypoxia will lead to increased erythropoietin, and that lead to secondary polycythemia. Well, respiratory acidosis with compensating metabolic alkalosis, CO2 is 55 millimeter mercury. That again indicates respiratory acidosis. Even the pH is 7.30. That really confirms. Well, as far as metabolic alkalosis is concerned, in the question there is nothing mentioned about bicarbonate. Okay. Nothing mentioned has been bicarbonate, but definitely when the respiratory acidosis occur, kidney really try to excrete more and more acid, and that lead to metabolic alkalosis. Pulmonary hypertension, this is due to chronic hypoxia. Chronic hypoxia, and that due to vasoconstriction. Hypoxic vasoconstriction. Okay, and hypoxic vasoconstriction due to pulmonary arterial hypertension. Cor pulmonale. Now to write down the answer. What is cor pulmonale? And well, till date I have taught more than 2 lakhs. I have taught more than 200,000 people. 2 lakhs people. And can you believe it? This answer is not known to more than 99.9%. They don't know answer this question. So this is a prize-winning question. The gold medal question is there. So let's learn what is cor pulmonale. The answer to this question is it is the right heart enlargement. With or without right heart failure. Okay, secondary to pleura parenchyma, lung parenchyma, or chest wall disease. So it is the right heart enlargement with or without failure, right heart failure, secondary to pleura parenchyma or chest wall disease. The usual answer is right heart failure. No, it may or may not be there. Well, this gold medal question is there. Well, in this case, when we are talking about several mechanisms likely contribute to hypoventilation and resultant hypercapnia. Well, of course, obesity is the main reason which reduces chest wall and lung compliance. Definitely. And this lead to what? Decrease in tidal volume and total lung capacity, an increase in airway resistance also. Obesity contribute to this also. So as a result, higher level of ventilated drive are required to maintain normocapnia. But patient is not able to, because of obesity, patient is not able to breathe properly. Okay, but that is needed. Now, as I told you, patient is not able to breathe properly, so they have an inability to exhale excess CO2. During the day, due to persistent restrictions, this lead to CO2 accumulation overnight and subsequent chronic respiratory acidosis. Well, patient is trying to move, that generate more and more CO2, but she's not able to exhale. CO2 is accumulating. At night, when she sleeps, she's more of a chronic respiratory acidosis. Now, one thing more additional knowledge for you. Usually also at night when we sleep, we all tend to retain some amount of CO2. This is normal phenomena. So if you check the ABG at night as compared to daytime, the slight amount of acidosis is there. It's more of a respiratory acidosis. Well, it's a very, very important point. Now I have a question for you. This worth $1 million questions there. Tell me any disease you know of which get activated or get precipitated due to respiratory acidosis at night. And this disease is, okay, I give a clue also. This disease is related to not due to respiratory system, but it's a disease related to hematology. So the question, now I've made your question very easy. I give you a beautiful clue that we have a disease in hematology which get precipitated at night because of mild respiratory acidosis which happen normally also. Write down the answer. The answer is PNH, paroxysmal nocturnal hemoglobinuria, which is a complement mediated RBC, WBC platelet, RBC, WBC platelet, and complement is there. And of course, there is a deficiency of CD55 and CD59, which are the membrane protecting protein. They are deficient, and co-complement can lead to intravascular hemolytic anemia. And the classical finding is, again, a question for you. Tell me, what is the classical problem with which the patient comes to the doctor? Write down the answer. Well, the answer is first morning urine sample is black. Whole day urine is normal at daytime. And this, as I told you, the complement get activated due to respiratory acidosis at night. So we got extra knowledge. We come back. Well, as I told you, as chronic acidosis is there, respiratory acidosis. Renal bicarbonate excretion is decreased as a compensatory mechanism. Body will try to retain more and more bicarbonate to compensate for increased CO2. And this blunts the ventilatory response to the increased CO2 and contribute to hypoventilation. So this is another mechanism by which hypoventilation will be happening in these patients. Okay. Well, in summary, patient with OHS, they cannot breathe due to excess body weight and altered lung mechanism. Won't breathe. Look, this is can't breathe. This won't breathe. Decreased chemosensitivity to hypercapnia from persistent nocturnal hypoventilation because of associated alkalosis, metabolic alkalosis. Well, let's look into other option. Option A is airway inflammation and bronchospasm that classically occurs in asthma. In asthma, we have a wheeze also, cough also, okay, and dyspnea also. This is a classical triad. Triad is asthma is dry cough, wheeze, and dyspnea. Okay. What about, well, in our case, this is not a case of asthma, definitely is a, okay, this is a case of simple OHS. Now, let about left ventricle contractile dysfunction. That means this is a case of systolic heart failure. But in systolic heart failure, we tend to get more of a crepitation also, and we may get some finding in lungs, but everything is normal. But this patient is at risk for diastolic heart failure as a result of likely prolonged uncontrolled hypertension. But she has a clear lungs and minimal lower extremity edema, so heart failure is very, very unlikely. What about neuromuscular dysfunction which occurs in disease like myasthenia gravis, amyotrophic lateral sclerosis, and Guillain-Barré syndrome? They can lead to hypoventilation and dyspnea, definitely. But in such cases, there should be some CNS or neurological findings should be there. But in our case, this is totally normal. So this is very unlikely to have any of this problem. And moreover, in this patient, elevated BMI and lack of any neurological symptom, which is more likely to the diagnosis. What about ventilation perfusion mismatch? This classically occur in pulmonary embolism, pneumonia, pulmonary edema, and ARDS. These are the important conditions where ventilation perfusion. Ventilation means like ventilation, air goes is ventilation, and blood goes, lung is perfusion. Well, in these cases, there will be gradient should be increased, alveolar and arterial gradient, what we write as PaO2 minus PaO2. This is arterial. This is the alveolus, gradient increases. And moreover, hypoventilation causes hypoxemia, PaO2 less than 70. But this gradient remains normal in OHS. But now, in ARDS, hypoxemia is there, but the gradient is increased, and this is remain normal in OHS. Well, again a question for you, write down the answer. What is the reason? What is the basic mechanism where in these cases hypoxia occur and elevated the gradient occurs? Write down the answer in your copy. To know this, we got to learn the basic. This is the alveolus, A for alveolus. This is artery or pulmonary artery or arteriole to be more precise. Normally oxygen goes like this and CO2 comes out from the arteriole. Okay, this is normal. Now in ARDS, the problem is this is the interstitial space, and this interstitial space is full of protein-rich fluid. This is the protein-rich fluid in the interstitium. That's one of the basic, and this is all due to problem of the endothelium anyway. And this is the reason why lung becomes stiff lung. This is there. Oxygen is a water insoluble gas. So this cannot come in. So this is the air coming here in the arteriole. This is PaO2. And here it is PaO2. Oxygen cannot go in, so it will remain low. And this is oxygen come and goes back. So ventilation is there. Ventilation is there, but perfusion is there, but the oxygen cannot go in. So there is wasted ventilation. So this is a mismatch. So now the gradient PaO2 and PaO2 will increase because oxygen not coming in. CO2 can very well go out. It's a water soluble gas. It is a CO2. CO2 is a water soluble gas. So in ARDS, you get hypoxia and you get hypocapnia. That means you get type 1 failure. Type 1 respiratory failure. And there is an increased failure. There is an increased PaO2 gradient will increase. That's the basic mechanism. I hope you are much wiser now. So a quick recap of the LMRP. Last minute revision point: obesity, hypoventilation syndrome. The diagnostic criteria: obesity with a BMI of more than or equal to 30 kg per meter square. Awake daytime hypercapnia more than 45 millimeter. Alveolar hypoventilation and no alternate cause of hypoventilation is there. Well, when we do the workup on ABG in room air, hypoxemia, hypercapnia, normal AA gradient. Respiratory acidosis is the result of altered lung mechanism due to obesity and hypoventilation. No intrinsic lung disease. Normal TSH, that may be ruled out hypothyroid. And polysomnography is the one which can be used to confirm especially obstruction, sleep apnea. Treatment, nocturnal positive pressure ventilation is the first line therapy. Problem is of the patient not able to breathe. That there is no role of any bronchodilator because there is no problem in the airways. Weight loss is the most bariatric surgery is in selected cases. Avoidance of sedative medication and respiratory stimulant like acetazolamide as a last resort. Golden line to remember, OHS is defined as obesity, BMI more than 30, daytime hypercapnia. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.